Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Oral Naltrexone, not a primary medication-assisted treatment, but still worth knowing. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and myself, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions through as you may think of them, and the presenter will answer questions at the break and then again at the end of the presentation today. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. But if you do experience poor computer audio, there are a few options to try on screen right now, and I've also posted these in the chat panel too, if that's helpful. If you continue to experience a loss of audio or poor audio through your computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen as well to receive a statement of credit. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. Also, a PDF version of this PowerPoint presentation will be emailed to participants also within 5 days. As many of you know, FADA produces many webinars through the support of the Florida Department of Children and Families. To help participants track credits earned through webinar attendance, we have launched a new website that provides a personalized digital journal where participants can maintain evidence of attendance for every webinar and workshop taken through the Florida Alcohol and Drug Abuse Association. So at the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will be prompted to register or log in to complete the evaluation, and you may register as a visitor. And do keep in mind that any information you provide FADA as part of registering does remain confidential. Also, as usual, completing the evaluation is necessary to receive continuing education credits or to access a statement of credit. Once your attendance and the evaluation are verified, you'll be notified that your statement of credit is available within your own member profile. Please do be aware also that the evaluation will close at midnight on Thursday, March 22nd. And we do expect posting of credits to take about 5 days, although we will try to work through verification earlier as possible. And again, you will receive an email from info@fada.org when your statement of credit is posted. If you are a Florida licensed healthcare practitioner, please be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. Note also that WebEx does monitor arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or certificate of attendance if you do not attend the entire webinar, and we're not permitted to provide partial credit. I'd like to introduce our presenter for today's webinar. David Gastfriend, MD, is Senior Research Scientist at the Treatment Research Institute. An addiction psychiatrist, he directed addiction research at Massachusetts General Hospital and was an investigator in the NIDA Cocaine Collaborative Study, the NIDA Combined Study, and the NIDA Clinical Trials Network. As Vice President at Alkermes, Inc., Dr. Gastfriend conducted biological, clinical, health economics, and policy research on behalf of the company's efforts in the field of addiction treatment. For 25 years, Dr. Gastfriend served on the faculty of Harvard Medical School, notably as the director of the Addiction Research Program at Massachusetts General Hospital and founder of the MGH McLean Hospital Fellowship in Addiction Psychiatry. He is considered the world's leading expert on two important treatment tools from both the biological and psychosocial realms: the opioid blocker Vivitrol and the American Society of Addiction Medicine criteria software. And I'm very pleased now to have Dr. Gastfriend join us today. And Dr. Gastfriend, if you're ready, I'm going to turn over control of the presentation to you.
Great. Thank you very much, Lan. And thank you, everybody, for joining. We have several dozen people on the line. And I'm pleased that there is this interest in oral naltrexone, which is not a primary MAT, but it's still worth knowing. And you can see my affiliations on the screen. They include both commercial and academic. And I will share with you my disclosures, because I do have financial disclosures that you should be aware of. One is that I work with ASAM, the American Society of Addiction Medicine, through my company Recovery Search, and I receive a royalty for the software that I developed for them and continue to support. I also hold salary and stock in two companies, Dynamic Care Health, and that is a company that produces contingency management services through a smartphone app. I also, as you heard, worked on Vivitrol development and research for a decade, and I continue to hold stock there. And these are some of my other financial conflicts that you should be aware of. Today's webinar is about oral naltrexone, and you'll see me abbreviate naltrexone as NTX, so that's just naltrexone. It's not naloxone, so let's not confuse that. That's often abbreviated as NAL, naloxone. But this is about naltrexone, and it's particularly about the oral form, which is usually a once-a-day medicine. So oral naltrexone is abbreviated as NTX-PO, per oral. And it's a potent blocker at the brain's opioid receptors or endorphin receptors. So it was a natural consideration as a medication for addiction treatment. And that is abbreviated as MAT. And you might see MAT spelled out as medication-assisted treatment, and that's the more common way of seeing it. But some of us are trying to encourage the field to change and modernize this. We don't like the term medication-assisted treatment, as if treatment is not medication, treatment is something else. The reason we don't like that is because it demedicalizes addiction and opens it to more stigmatization. So if we think of medication in addiction treatment as a normal, usual component of treatment along with counseling or psychosocial services, then it destigmatizes the field in general and keeps it within the realm of normal medical services. So we're going to focus on opioid use disorder, which is abbreviated OUD, and think about what the role of naltrexone oral is. For most patients in opioid use disorder, studies have not found OUD patients to respond any better to Naltrexone PO than to placebo. And that is surprising because the molecule works, and I'll show you how it works, but because of poor adherence by patients, we don't end up seeing the clinical benefits in practice that we might see in some of the research studies. Nevertheless, it's not something to be forgotten or thrown out. It's still used for patients whose pill taking can be regularly monitored. It's still used for detoxification and induction onto extended-release naltrexone, which is also Vivitrol. It's still used for patients who have completed NAT, maybe with methadone or buprenorphine, or even with Vivitrol, but who subsequently encounter new stressors for which they might want temporary protection from relapse because you can take it one day at a time. So the objectives of this workshop are that by its end, in less than 2 hours, I hope you will understand the brain receptor effects and clinical effects of oral naltrexone. I hope you'll be able to describe the limitations of oral naltrexone in practical clinical care. And I also hope you'll be able to understand the appropriate roles of oral naltrexone use in opioid use disorder, because it does still have roles, and therefore it's still worth knowing. Now, one of the primary effects of naltrexone has to do with brain reward. And brain reward is a neuronal process that's been in the brain for much of evolution. And this slide sort of jokes as to where it's going, which isn't necessarily so healthy. But brain reward is actually not just present in humans, not just in primates like the chimpanzee, not just in mammals, but even in birds and reptiles. In fact, it emerged as a definitive system going back to the time of the reptiles and the dinosaurs, hundreds of millions of years ago. And it's such an important driver of behavior that it has survived in evolution for these hundreds of millions of years. So it is very powerful. And I'll say more about that in a moment. One of the things we can see with brain reward is the actual form of brain activation. This is functional MRI imaging where people who are either social drinkers or alcohol-dependent individuals are shown pictures of their favorite drink, and we see what happens in their brain. Now, in social drinkers, you see in this outer region of the brain where we have the white and gray matter. This is the thinking region of the brain, the cortex. And you see an activation. The cortex is recognizing, oh, that's my favorite drink. I like that drink. So I like the taste. So I like the flavor. And those cues produce some activation. That's what that orange region is. It's brain activation. But if you look at the alcohol-dependent individual's brain, way down below the folds of the cortex, the thinking brain, you see in deeper structures big regions of activation. And this is because the alcohol-dependent individual is habituated to the brain reward, the positive reinforcement, the excitement, the euphoria, unlike social drinkers. Now, why am I showing you this picture with alcohol-dependent individuals? And we're talking about opioid use disorder. The reason is these disorders are almost the same in terms of the regions of the brain that are activated by the excessive brain reward of these drugs. So we get the same picture if we do this with showing heroin paraphernalia to heroin addicts. There are two key regions we can think of in understanding the brain structure of addiction. Now, I'm simplifying, but it really helps us understand, and it's also very helpful in explaining this to patients. So think of these two brain regions, cortex, this outer region where all the folds of the gray matter occur, and this inner region, which is called the limbic region. Sometimes it's called the drive region of the brain. In the cortex, the role of those neurons is decision-making, thinking, reasoning, learning. The stuff we pride ourselves in as Homo sapiens, as human beings. And we have the largest cortex in the animal kingdom. But there is a deeper region called the limbic region that evolved much earlier in the course of evolution. And it's actually very similar, not just in structure, but in design and in size even. It's a small region in the human brain, and it's about the same size in many of the lower evolutionary chain animals. And it's responsible for basic drives and the experience of reward and euphoria. So if we want to address the problems of excessive reward, we need interventions. Now, in the cortex, these interventions are things like psychosocial therapies, counseling, 12-step programs, and monitoring. But these are talk therapies. These are relationship therapies. These are interactions with the thinking human mind, and that resides in the cortex. But the interventions we need for the limbic region have to be chemical, because this region is below consciousness. It's subconscious or not conscious. And we need medications. We can use agonist medications like methadone or buprenorphine to intervene here and stabilize the opioid-addicted brain. Or we can block opioids completely with antagonist medications. Antagonist just simply means anti, against. So these medicines like Naltrexone are against the opioid effect. They block the effect. Now, I mentioned that this is an oversimplification, and two regions is hardly representative of the full extent of the brain's complexity. We could look at it with a little bit more complexity in terms of the reward system, which is what I was talking about before, the nucleus accumbens, the ventral pallidum, where we memorize or learn the things that trigger our rewards, the amygdala and hippocampus. The systems in the outer brain, the cortex, that are directly recruited to act based upon the rewards. This is our motivational drive system, the orbital frontal cortex. But there was another system that we should talk about, because motivation and reward is part of what we call the go signal, but there is also an inhibitory signal, the no-go signal, and both of these are disrupted in addiction. So, for instance, the inhibitory control system is responsible for stopping us from going after something that would be rewarding but might be dangerous. So if you think about the caveman and his cave woman and the cave baby in the cave, and they're starting to get hungry, they haven't eaten in a day, and the caveman looks outside the cave and smells a rabbit, and he says, "Oh, delicious rabbit." He's going to go out and capture the rabbit until he hears a rushing in the tall grass, and he realizes there's a saber-toothed tiger. Well, the go system wants to go after the rabbit, and the inhibitory control system says, "Don't go out yet, you'll get eaten. Wait till the saber-toothed tiger leaves." And it's that balance of these brain regions and their signals that is critical for survival of the species and our healthy lives. So we need both go signals and no-go signals to be functional. And unfortunately, both of these are disrupted in opioid use disorder. How does this happen at the cellular level, at the level of neurons? Well, brain cells, neurons, secrete a natural amino acid called dopamine. This is a small molecule that our brain makes every day, all day long. And it stores it in little tiny bubbles. And it releases these bubbles at a steady rate, and it increases the release of this if we're hungry and we get food, if we're thirsty and we get fluids, and if we're ready to procreate, to begin having sex in late adolescence, and we have sexual function and orgasm, and that rewards survival behavior for the preservation of the species. So dopamine is one of our most fundamental behavioral drivers. And as it flows across the synapse, the space between nerve cells, neurons, it attaches to receptors that are specifically designed for dopamine. And when it attaches to the receptor, it releases essentially a flow of energy. And that flow of energy sustains transmission from one neuron to the next neuron. It's our wiring system. Our wiring system is both electrical and chemical, and dopamine is key for motivation. Now, there's another naturally secreted chemical in the brain called endorphins. And endorphins are produced when we have pain and we need pain relief, also for stress relief, also for emotional bonding. So they're very important as well. We can secrete the endorphins naturally, or we can take drugs that mimic them. So heroin and the opioid painkillers, the opioid analgesics, can be swallowed or injected or snorted. They get into the system, into the bloodstream, into the brain, and they'll float into this synaptic space and attach to our natural opioid receptors. When endorphins or opioids, the drugs, reach the opioid receptor in the brain, they trigger an excessive release of dopamine. And that excessive release of dopamine produces excessive energy. And that produces more go. In fact, it's more go than is naturally healthy. So we have opportunities to disrupt this process. We could stop the opioid analgesics and heroin with slower, longer-acting opioids like methadone or buprenorphine. These activate the opioid receptor, but they do it slower, which is less reinforcing, less addicting, and they do it for long stretches of time. Methadone is 24 hours, buprenorphine is 36 hours. And that effective time slows down the brain's activation and its excessive reward, excessive go, and allows time for some fading, some extinction of this memory of excessive pleasure or reward. Partial agonists, like buprenorphine, do the same thing as the agonists. They act like opioids. But buprenorphine does it to a lesser effect. There's a ceiling it can't go above. It produces an opioid effect that's only maybe half of what methadone does. So whereas methadone might produce less of this because it's slower onset and longer acting, buprenorphine produces even less, although still more than our natural amount of energy results. What does an antagonist do? And I said antagonist means anti-against. Well, an antagonist like naltrexone blocks the opioid receptor completely. So this yellow plug essentially attaches to the brain's opioid receptor, but it blocks it so that other opioids can't get to the receptor and produce that excessive energy. The circuit in the brain is also pretty well understood. If you think of a very central region of the brain called the arcuate nucleus, that releases endorphins, our natural opioid painkillers, to different regions of the brain. It can do it indirectly through the ventral tegmental area, which then increases dopamine transmission to the nucleus accumbens, or it can happen directly through a different circuit with opioid peptides directly triggering increased secretion of dopamine from the nucleus accumbens and then on to the frontal lobes of the brain. So naltrexone will block each of these regions because they each have opioid receptors that can be blocked and prevent this natural effect from happening, or at least lower it somewhat. And it does lower it somewhat. We'll talk about that as a side effect of naltrexone, although it's not clinically very important. But more importantly, it'll block unnatural opioids, heroin, OxyContin, all of those, morphine, codeine, from reaching the brain's opioid receptors. And that's how naltrexone works in the brain circuits. The effect of that, if we want to graph it, is no effect when we blockade the receptor with an antagonist, and whereas buprenorphine produces maybe a 50% opioid effect, and methadone produces a full opioid effect, an antagonist like naloxone or naltrexone produces zero opioid effect. So the patient doesn't have any opioid experience whatsoever. So to summarize the neurobiology, we have opioids acting at various regions in the brain, the circuitry where the mu opioid proteins bind to these agents and diminish dopamine effect. So the opioids produce increased dopaminergic reward, positive reinforcement, and over time, later, they actually change the brain's wiring. They increase the expectation of opioids and decrease the positive effect so that the patient wants more and more. And it does this through actual chemical changes in the brain. And recurrent withdrawal has another effect. So far we've talked about positive experience, reward, pleasure. But recurrent withdrawal actually has a negative effect. It punishes the brain. And that makes people want to use more also. So that's another cause of reinforcement. We can have positive reinforcement. I feel good, therefore I want to use more. And we can have negative reinforcement. I feel bad during withdrawal, therefore I want to use more opioids again. And that reinforces recurrent use. We even understand how the negative reinforcement occurs. There is the dynorphin system, which leads to aversion, anhedonia, and depression-like symptoms. And there's also a disruption of the stress response system, the HPA axis. So if we want to treat this disorder, we have to recognize that it's a biopsychosocial and even spiritual disorder. And that means we need chemistry, yes, to stabilize the system, and that's a physical effect. But we also need treatment, counseling. So we need to either detox the patient, achieve a medical withdrawal, stabilization of the body function, or we need medications like methadone or buprenorphine to also stabilize the brain system, including stabilizing withdrawal. But then we need behavioral therapies, and there are many of these, some that we don't use enough, including contingency management, and I've already done a webinar on that for you, and recovery support services, wraparound services. Another aspect of this is dealing with the negative reinforcement issues. We need to sanction patients in a measured way, a prompt way, a scientifically sound way, so that the no-go system, the inhibitory control system, comes back and does its job. Because only addressing the reward system, the go system, is only dealing with half of the problem. The no-go system, the inhibitory control system, also has to be improved and healed. So the goals of pharmacotherapy in OUD are, well, okay, first we have to manage withdrawal. But that's not treatment, really. That's just chemical stabilization. In this country, most of our treatment is detox without continuing medication and addiction treatment, and that is inadequate care because it's not chemically sound for the brain to go with these altered brain systems without any further stabilization. And that altered system is staying that way for months. So at least for months, we need to be treating people with continued medication well beyond detox. Early recovery protection is the true goal of pharmacotherapy. This is the period at highest risk for overdose. If you look at people coming out of jail or prison, different studies show that their death rates upon release from prison or jail in the next couple months is anywhere from 12 times that of the general population to 100 times that of the general population. And so we need to achieve harm reduction, and medication is by far the best way to do that. So harm reduction is our first goal in early recovery. And it's not just to protect people from death, it's also to reduce HIV transmission and hepatitis C transmission. And it's been very well established that both of these benefit from pharmacotherapy in addiction treatment. We also need an anti-craving effect because craving persists well after withdrawal and provokes relapse. So just to permit counseling, to have the patient capable of focusing, we need to be protecting people from craving. And the medication that we use is critical to achieving this. But there's a lot more that should be our goal of pharmacotherapy. We want stress response to be normalized because opioid use disorder disrupts the ACTH and cortisol secretions that are the stress hormones of the brain and the body. But we need some more. We need the psychological process of extinction. Now, extinction means, when the animals die out. But it also means when our reactions to the cues of opioids, for a heroin addict, seeing needles, going back to the neighborhood where they would buy drugs, they stimulate an excitement in the brain, and that's a learned response. The purpose of pharmacotherapy is to allow time for those memories to become less salient, less exciting, and weaker. So the fading of positive and negative cue responses is very important, and it takes many months, and for some people even years. We need other biological stabilization to happen. For instance, we need people to start eating again. We need the diurnal sleep-wake cycle to come back. Sexual function needs time to come back. The capacity for self-care, activities of daily living. We need to stabilize the body so that the individual will stay in treatment and pursue their general health care needs and reestablish relationship bonding. We also need people to eventually find their purpose in life, find a way that life has meaning. This is the spirituality component of the biopsychosocial spiritual disorder of addiction and the need for recovery. So chemistry, pharmacotherapy, MAT, is not recovery. Yes, it is treatment in addiction, but it's not recovery. Recovery is very different. It's disease acceptance, it's coping skills, it's rehab, it's return to functional life relationships and finding purpose and meaning in life. So let's talk about some of the primary effects of naltrexone and the basics of what we can expect and what we cannot expect. The primary effects of naltrexone, you already know. Oral naltrexone can block the reinforcing effects of opioids. That has a lot of other benefits. So for instance, I'm getting very specific now. Naltrexone-PO can markedly diminish or even eliminate the ability of an individual to tell if they've even gotten an opioid. If somebody is on their daily pill of naltrexone and they take a Percocet, they can literally not feel it. They can't even tell that they've got it. That's called eliminating opioid discrimination. It can eliminate opioid mood effects. So if people say, oh, it's calming, oh, it reduces my anxiety, oh, it lifts my depression. Well, guess what? If they are on naltrexone, they won't feel that mood effect. They might get some placebo effect because they think they took an opioid, but they're not going to have any biological effect from the opioid itself. It can block opioid self-administration. In studies, when we know people have taken the naltrexone oral medicine, they actually stop taking opioids because they don't do anything. So people give up. And in carefully controlled studies, we can see a reduction in craving with opioids. The problem is we don't see that in real practice. And that's because people don't take the pills consistently. Now, in the bloodstream, when the patient takes their daily oral naltrexone, and the typical dose is 50 milligrams a day, that's the standard dose, that's the size of the pill, they get a peak of naltrexone in their blood plasma, and every day it goes up and then it goes down. The next day, if they take the pill, it goes up, and by the end of the day it goes down. So you get this, we call it a sawtooth pattern. The problem is if they skip one day, their next 24 hours has basically zero naltrexone in their bloodstream, and that means at their brain. So it's not effective if the patient skips a day. And that is the key vulnerability, the Achilles heel of naltrexone treatment, compared to, let's say, extended-release naltrexone, Vivitrol, where you get a peak, you get another peak, and then you continue to have a measurable amount of naltrexone in the bloodstream beyond 30 days. So this is the key vulnerability, the weakness of oral naltrexone. So the benefits of naltrexone oral are it's a daily oral pill. Well, that's great. It's convenient. It lasts all day long, which is a good thing. And it's not a controlled substance. There's no euphoria, no high, no reward. So it doesn't have any street value. It doesn't have any diversion value. And patient won't like it too much. It's not reinforcing. They don't get a pleasure from it. So they're not going to overdo it. So these are the benefits of naltrexone PO. Daily oral, not controlled substance. Patients won't like it too much. What are the problems of naltrexone PO? Daily oral pill, not a controlled substance. Patients won't like it too much. Aha. The same benefits of it are also its underlying weakness. Because it's a daily oral pill, yeah, the patient has convenience, but they can skip it. That's convenient to do too if you want to get high. It's not a controlled substance. You don't get a reward. Well, that's a strength, but it means the patients don't want to just start off, yeah, let me take that. It doesn't feel appealing. And the fact that they won't like it too much, well, that's a strength, but it's also a weakness. So these problems and strengths are identical, unfortunately. Going into a little bit more detail, the single-dose pill means you don't have to adjust the dose, you don't have to taper it on, starting lower and going up slowly like you would with methadone or buprenorphine. You also don't have to taper it off. At the end of treatment with naltrexone, you can just say to the patient, okay, you can stop this, cold turkey, and there's no problem. It doesn't have an opioid effect, so it doesn't need to be tapered or withdrawn. Since it's not a controlled substance, any licensed healthcare professional can use it. Since there's no overdose risk, there's no harm that the patient could kill themselves with it. There's no physical dependence to manage, as I said, and therefore there's no diversion. It doesn't have street value. And patients will test the blockade initially, but they don't have to test the blockade for it to work. This was one of the concerns that, well, the extinction happens when people use opioids, they see it didn't work, and then gradually they lose interest in using. Well, in fact, we now have studies showing that you don't have to test the blockade. It will actually decrease craving and have the beneficial effects, even if the patient never tests the blockade, which is a good thing. And that is true for extended-release naltrexone as well. But the limitations are pretty substantial and pretty dramatic. It is clearly, in studies, less effective than other MATs, and it's not significantly more effective than placebo for the vast majority of patients. So we'll say one more thing about the effects of naltrexone, and then we're going to take a little break. So another nice thing about naltrexone oral is that except for blocking opioids, which can produce a drug interaction, that means if the patient's on an opioid and they take naltrexone, they'll go into precipitated withdrawal. So that's a drug-drug interaction. But aside from that, there really aren't much in the way of, there aren't much problems in terms of drug-drug interaction. So it's a really safe medicine for most patients to take. Now, that opioid blockade is a big deal. It interacts with all opioids. It will produce this immediate, rapid, what we call precipitated opioid withdrawal. And that's not a side effect, because it won't happen if you just take the medication without any opioids on board. So it's not a side effect, but it is an adverse event, and it's not just annoying. It's much worse than that. Precipitated withdrawal is worse than tapering a withdrawal. It's worse than cold turkey withdrawal. Cold turkey withdrawal is, I just stopped my heroin, now I have no heroin. It's tapering off in my bloodstream and in my brain over the next few hours, and I'm gradually, over the next several hours, going to go into more and more withdrawal. Okay, but that's over many hours. With naltrexone, if the patient's using heroin and you give them naltrexone all of a sudden, they go into immediate 100% on the, on the mark withdrawal in a matter of a few minutes. And if you cause precipitated withdrawal with oral naltrexone, the patient may never want to be in treatment again. That's how unsettling it is for patients. So those are the principal drug-drug interactions with oral naltrexone, and that means it's a remarkably safe drug. If only it would be effective. So I want to entertain any questions from this background before we get into the next section. In the next section, I'm going to talk about how do we know that it's not effective? Why did we think it was effective? And for whom is it not effective? And if we have data on for whom it is not effective, who would it be effective for? Under what circumstances should we use it? And is it at all worthwhile using? Is it cost effective? And should we take the costs into account in choosing who should we offer it to? So I'm going to go through all of those topics in the second half of this webinar. But before I do that, if you can type in to your Q&A window, and at the top right of your screen there should be a Q&A icon to click to open up the Q&A box, and then type your questions into the Q&A box if you would. If we don't have any questions yet, we'll take a break for 5 minutes and then come back, and then hopefully some of you will have some questions, and I will be glad to go through those questions. The first question that has come in from Jeff is, if possible, can you comment on the recommended anti-craving medications? And that's a very appropriate question for what I've discussed so far. So let me answer that. Anti-craving medications include oral naltrexone, extended-release naltrexone, Vivitrol, methadone, and buprenorphine. And buprenorphine's brand names include Suboxone, Subutex. There are films now, the strips. There is even a 6-month implant called Sublocade. So those are all the FDA-approved anti-craving medications. Another question has come in from Suzanne. Do you think we're moving away from the idea of methadone? That's a really interesting question. And you might think that we're moving away from methadone because we have buprenorphine, and buprenorphine is now, I think it's selling like 4 times the rate of methadone. And we also have extended-release naltrexone, Vivitrol, and that is now growing rapidly throughout the country as well. But in fact, we're not moving away from the idea of methadone. Methadone has increased substantially over the last 5 to 10 years. And it's hard for methadone to increase because you have to establish new methadone clinics. And despite the fact that it's hard, people don't want it in my neighborhood, so we have that problem, not in my backyard, NIMBY, objecting to the growth of methadone. Nevertheless, methadone has increased substantially. I think it's doubled in 10 years. So we're not moving away from it. And the reason is, it's a very good medicine. Now, it's not a good medicine for everybody, but for people who have very chaotic lives, who don't have a daily schedule, who can't take care of themselves, who have lots of stressors and disruptions and are highly impulsive and responsive to cues of drugs. Methadone is very stabilizing. So it's still a good medicine, and it is an anti-craving medicine. So those are great questions. Let's take a 5-minute break. It's 10:45. If you can come back at 10:50 a.m., we will continue with the second half of the webinar.
Thank you, Dr. Gastfriend.
Okay, we're going to get started again, and welcome back to everybody. The next portion of the webinar is going to be more detailed because we're going to look at how it is that we know that it works and how is it that we know that it doesn't work in practice. So here is a study of oral naltrexone medication. This is an alcohol use disorder. So again, I'm using alcohol as an example because whatever is true for naltrexone in alcohol use is even more true in opioids, and I'll tell you what I mean by that as I go along. So here is a meta-analysis. This is a study of studies. If you take a half a dozen studies that were published in the scientific literature and the peer-reviewed journals, and you analyze how much effect did the medication have compared to placebo in each of those studies, and you find a way to average them. They report their data a little differently, but you come up with a statistical way of averaging the effect size, the size of the effect, across the different studies. And what you find is that the earlier studies, when they first started testing oral naltrexone for alcoholism, they found that, hey, look at that, it seems to work. And a bunch of studies indicated that it could be an effective treatment. So that was exciting. And as a result, the government funded more studies, larger studies, and better studies, multi-site studies, to look at, does this hold up over time? So we saw that it does work for alcohol use disorder, but as the studies got more sophisticated and more multi-site, where they had a broader population, guess what? It didn't look as good anymore. So in the beginning, you see an effect size, that's this graph over here, and the effect size is a 30% effect size. So that's okay. That's, it's modest, but 30% better percent days abstinence over 3 or 6 months of treatment, if you can improve abstinence by a third, that's worth having. And these initial studies look pretty good. But look what's happening over time. As you get more studies, and the size of these little circles is the number of patients in the study. So this study is a big study, lots of patients. And these are getting lower and lower. So from 1992, when the first group of studies came out, to 2009, this trend line shows a drop over time. And we're getting less and less effect from percent days abstinence, to the point that we're almost at zero. This is the zero line, no effect. And we're getting pretty close to that. And that's looking at percent days abstinent. If you look at relapse to heavy drinking, so we're not eliminating drinking, but we're reducing the return to heavy drinking. Okay, that's not as dramatic a clinical benefit, and people are still drinking something, but it's worth achieving if you can do it consistently and safely. So here, you're getting a better effect. The oral naltrexone for alcohol treatment was more than half the time, 0.6%, 0.6 effect size in the beginning. But look at the decline in this line over time. This trend line is getting worse and worse, to the point that these studies are showing no effect, or placebo is doing, if anything, maybe a little bit better than the naltrexone in some of these studies as you get later on. So what we saw over time is that oral naltrexone showed less and less benefit. And even in the beginning, its effect size was modest. It wasn't very big. And it wasn't for the gold standard of abstinence. It was more for just reducing heavy drinking. So the effects in these studies appear to have attenuated or decreased over time, and the factors that explain these decreases aren't very clear. We don't really understand why these studies haven't been able to show the benefit over time. So that's an alcohol. What about an opioid dependence disorder? And here's the same kind of systematic review of many different studies, and they even looked at the economics in the study as well. Now, an example of a study in opioids using oral naltrexone is this one by Krupitsky. And Krupitsky found that in the beginning of his trial, after detox, in the first week, 60 to 70% of patients were staying drug-free. But over time, they actually increased their drug use. And there wasn't any difference between these two lines, between the naltrexone group or the placebo group. So this isn't a significant effect in opioid use disorder with oral naltrexone. And if you look at the group of these studies, this is a way of comparing multiple studies. There's a whole bunch of them here, including Krupinski. And if this risk effect, this relative risk of stopping treatment, is calculated out at 1, they're equal, 1 to 1, no difference. If the risk is reduced by 50%, say 0.5, that means the naltrexone has done a good job. It's reduced the risk of dropping out of treatment. So this is a retention analysis, and we're looking at the risk of stopping treatment. Can we reduce the risk of stopping treatment? But what you see is, in these box and whisker plots, the box is the average, and the larger the box, the more patients in the study. The whiskers, these lines, that's the standard deviation, the variation in the finding. What you find is that the average of all of these is this big diamond-shaped box here, and it's very close to 1. In fact, it overlaps 1 with its whiskers, which means it's not significant. So across all these studies, there's no effect, no benefit of oral naltrexone reducing dropout from treatment. And here's the retention across all these studies. There's the average, and the top line is the upper end of the standard deviation, and the bottom line is the lower end. So just look at the middle one, the solid line, and you see that by 12 weeks or so, half the patients are gone. They're dropping out when you look across all these different studies. So that's not very good. It's not helping retention. And data on retention from 7 different trials shows this, and maybe there is a slight reduction of 6% less dropout compared to placebo, but that's not significant statistically, and it's not very much either. It's really minimal. So we have to start asking the question, does that mean it doesn't work at all? Or does it mean it doesn't work for most people? And if it doesn't work for most people, are there some people for whom it does work? So we're going to ask this question on and on now. What is the benefit, and for whom is the benefit? So one of the problems is that only a portion of opioid use disorders will even, only a portion of the patients will even accept oral naltrexone. And if they accept it, only a portion of them will persist on it. But there is some evidence that certain patients are more likely to benefit than others. For instance, patients who are employed, patients who are married. If they're both employed and married, there's even more likelihood that they'll benefit from oral naltrexone. Now, in public drug treatment programs, patients with opioid use disorder, only 10 to 15% are even willing to try it. Nevertheless, that's not nobody. There are some people. If 1 in 20 patients, sorry, 1 in 10 patients, or 1 in 8 patients is willing to try it, we want to be able to offer it, right? And there are some efforts to deal with this problem of poor retention on it. And some of them have shown some benefit. So for instance, if you used oral naltrexone and contingency management, you could get a better outcome. You could get more retention. So what's an example of that? Well, this study showed that. And this is in an opioid use population, a 12-week trial, and the patients either got contingency management, that means they got voucher incentives for money or prizes, gifts, if they succeeded in taking their naltrexone doses. And another group got the vouchers, but they didn't get the vouchers based on whether they took their naltrexone. They just got that intermittently. So they might stay in the study to keep getting the vouchers, but it doesn't necessarily mean that they were reinforced to keep taking their medication. And then the third group didn't get any rewards. So those are the three groups, and let's look at how they responded. This is a measure of retention. At the beginning of the study, week 0, 100% of patients are in the study. Okay, that's great. All three groups, 100% are in the study in the first week. But then they start dropping off. Now, they're not expected to take the medicine every day. They're actually using doses. You don't have to give 50 milligrams a day, 7 days a week, which is very hard for patients to do. You could give 100 milligrams on Monday, 100 milligrams on Wednesday. That's just a double dose. It's not harmful. And on Friday, you could give 150 milligrams, a triple dose, and that's also not harmful. And that 100 milligram dose on Monday and Wednesday has some chance of hanging around for not just all day Monday, but well into Tuesday. And if you give 150 milligrams, a triple dose, on Friday, that has some ability to hang around not just Friday, but also Saturday and Sunday. So you have better coverage throughout the week, even though you're only taking it 3 times. And you can monitor if they're taking it the 3 times. You can have them come into the clinic and take the pill right in front of you, Monday, Wednesday, and Friday. Now you might think, well, that's kind of a hassle, but you know, we have methadone patients coming in 7 days a week, even holidays and Christmas, and weekends. So it can be done. And they reinforced people in the contingency group by giving them rewards every so often for showing up and actually taking their pills. And that group, the ones with the circle marks, is hanging around the longest in treatment. So whereas 50% were dropping out within 12 weeks in the meta-analysis of studies, 50% in this study less than 50% were hanging out for 12 weeks before. Now 50% are hanging out. And if they're just getting the reinforcements but not for taking the medicine, it's down to 20-something%. And if they're not getting rewards at all, in this study, they're, like 5% are sticking around for 12 weeks. So dramatically better retention with oral naltrexone if you reinforce people to take the oral naltrexone and you break it down into 3 days a week. So there are ways to improve the retention and the compliance with the medication. And of course, if they're compliant with the medication, they're not able to get high. So this is a really interesting finding that there are ways that oral naltrexone can work. You can look at these data a little differently. Here, all of the patients in the contingent group have a dot, and you can see the total number of naltrexone doses they took. Over 12 weeks, 3 times a week, it would be 36 doses for the maximum. And you can see quite a few patients took the maximum, and the average was decent. 21 out of 36 doses were taken. Substantially lower and significantly lower for the non-contingent group that got rewards to stay in the study but not to take the medicine, and way lower and very significantly lower if they weren't getting reinforced. So this is what the real population would do, and this is what the contingency management population would do. Okay, that's a good finding. And so what would happen with extended release naltrexone? How would that differ from oral naltrexone? Now, you know that extended release naltrexone or Vivitrol is a month-long, same thing, mu opioid competitive antagonism, just one injection, 380 milligrams into the buttocks, and the patient has it for a month. And they invented this because the NIH said, look, oral naltrexone meta-analyses are showing in 13 random controlled trials with 1,000 or more patients, 1,158 patients, oral naltrexone didn't reliably increase retention or abstinence. And in Canada, there was an analysis that found that people taking oral naltrexone who had gotten detox, they lost their tolerance, and they weren't complying with their oral naltrexone, they had 3 to 7 times the death rate of patients taking methadone. So that was a pretty concerning finding. So the NIH in the 1970s said to the pharmaceutical industry, please develop opioid blockers like naltrexone, but extended release. So extended release naltrexone, again, is a blocker, and so you have to be opioid-free. and you lose tolerance, so the patient has to be cautioned. And it has other issues, injection site reactions. There can be a little feeling of a withdrawal when people started, even if they've detoxed. And there were concerns originally about safety to the liver, but it turns out hepatic safety is not such a big deal, and there was a black box that was removed by the FDA. And again, just like oral naltrexone, there's no withdrawal upon treatment completion, and it's not a controlled substance. And it works for both opioids and alcohol dependence. Well, how do we know it works? And why does it work differently than oral naltrexone? And the answer is, if you look at the pivotal trial, the main trial that the FDA reviewed to approve extended-release naltrexone, in terms of retention, the placebo group stayed in the treatment. The average patient, the 50th percentile patient, stayed in the study 12 weeks. Well, we've seen that before with a good study using contingency management. But that's not great retention. And at 12 weeks, 70% of the extended-release naltrexone patients are staying in the study. In fact, the average patient, the median patient, in extended-release naltrexone is staying in the study an average of 168 days. That's the length of the study. So they're finishing the whole study on average, and the placebo patient is dropping out by halfway through the study. So if we can compare what we saw before, this middle line in the meta-analysis of 7 combined oral naltrexone studies versus the extended-release naltrexone study, so they're both on 100% retention rate on the same vertical scale. And we can see the curve with extended-release naltrexone is way higher than the curve with oral naltrexone. Now, they're not the same study, and they're not analyzed the same way, but basically this is the finding both in research and clinically, that it seems that we're getting better retention because the medication is staying a month at a time. And the patient doesn't have a daily decision, do I want to take this medicine? Now, it was thought that having a daily medication would be a good thing because it would force the patient to make a daily commitment to their recovery. The problem is, it's also a daily tease to the brain reward system. At the end of the day, the brain is able to consider, well, if I take this medicine, I'll be stable. If I don't take this medicine, I could get high. And that is a physical, chemical, biological provocation, a tease to the brain, to the reinforcement system. Hey, wake up, you could get high. So it turns out in reality that that is much more likely the problem, that it's not a daily intellectual commitment to, oh, I'm a believer in my biopsychosocial spiritual recovery. Well, that is cortical, that's cognitive. That does not trump the biological reward system in the limbic drive center. So, we have this difference between extended release and oral naltrexone, and there are other considerations as well. If we use it for patients who are motivated and can be monitored to stick with it, we can get a good clinical effect. But we do have to be aware of some contraindications. So let's just talk about some of the medical aspects. Acute hepatitis, you can't take oral naltrexone. It doesn't really damage the liver except in very high doses, but it can disrupt liver enzymes somewhat, and so it can be hard to track acute hepatitis or advanced liver disease. So we wouldn't use it in those conditions. If the patient has renal impairment of any moderate or severity degree, it is renally cleared, and so it would not be appropriate. If the patient has current suicidal or homicidal ideation, and if the patient is prone to worsen when they withdraw from opioids, it wouldn't be appropriate. And the reason is it can increase the patient's feeling of depression, sadness, desperation. It eliminates the coping mechanism that they've been used to. And so you can even see psychologically that it could disrupt their confidence, their comfort, and be a challenge. If the patient has opioids in their urines, if they failed the naloxone challenge, or you can do a naltrexone challenge with low-dose naltrexone, you don't want to give them the full dose of oral naltrexone. If they have chronic or acute pain, such that they might be needing opioid analgesics, opioid painkillers, you don't want to use it. And if they've been previously allergic to naltrexone, it's a no-go. So let me say more about pain, because patients do encounter pain. If they're going to have a chronic pain condition, you've got to use non-opioids to manage that. If they have acute pain, you know, they've broken their leg or they're going to have surgery, you need an anesthesia consult. The anesthesiologists know that any anesthesia will work fine with naltrexone, local, general, regional. But if they're going to use analgesic painkillers, then they have to manage that. Now, you can, for instance, skip oral naltrexone and the next day you're fine. So you can literally wait a day. Or you can delay surgery if it's elective until it's safe to stop the naltrexone. You can even override oral naltrexone, or Vivitrol for that matter, with anesthesia or high-dose opioids, but that requires tapering, titrating, and monitoring. And so you need to do it with somebody who's skilled in those things, using a crash cart if necessary. Cirrhosis is an important question. Naltrexone is metabolized in the liver. So if the liver enzymes, the AST or ALT, are above 5 times normal limits, you would withhold oral naltrexone. What about pregnancy? Well, there isn't a lot of research. There aren't formal studies. This is called a Category C medication. So we can't really tell the patient what safety or efficacy to expect if they use the naltrexone. So it's not barred, it's not banned from use in pregnancy, but the provider has to assess the risk-benefit ratio. And if you're going to prescribe this to a pregnant woman, she needs to understand the risk benefits, and she needs to consent to continue with it, because there isn't any, good research on it. One thing we do know about naltrexone oral and extended release is that in breastfeeding, naltrexone passes into breast milk. Not in high quantities, but it does get in there. And therefore, if the mother's going to stay on naltrexone, whether it's oral or extended release, breastfeeding should be avoided. So it's time to start thinking more precisely about for whom this medicine could be appropriate. If the patient is off of opioids, maybe they stopped using, but they keep relapsing, and they know that. Do you want to put them back on an opioid, like methadone or buprenorphine? Well, it may be that this patient wants to be off of opioids. They're not currently using, so they don't have to be withdrawn. And they have an opioid use history, and it's clear that they will be at risk for relapse. Well, that might be a good patient to be taking oral naltrexone, because they don't want to be back on maintenance of an opioid, and they're concerned about their impending relapse risks. If they have high motivation for abstinence, full abstinence. Now, there are people who say, look, doc, I don't want to get hit by that car again. I'm sitting here in your ICU after having all my bones broken because I was high, and I don't want to have the cellulitis that put me in the hospital last year, and I don't want to have the heart valve infection, the endocarditis. They put me in the hospital the year before that for 2 weeks with antibiotics. But I'm not giving up my heroin. Once in a while, I'm just going to use. Maybe it's because of my PTSD, maybe it's because, I don't care about what society says. This may be a person who's got some sociopathic traits and doesn't want to live life the way the rest of us do. And we may not, at least for quite a while, have much to say or do about that. So if that patient is going to continue using opioids, they're not going to benefit from oral naltrexone, and we don't want to use it. We actually want them to be on a drug like methadone, because then they'll stabilize their life. They will feel an opioid effect. If they choose to use heroin on it, they probably will not overdose, and methadone would be the right choice for them. If they're motivated, however, to undergo detox, and they have a strong desire to be opioid-free, oral naltrexone could be the right medicine. If they're really opposed to methadone or buprenorphine, or maybe they were on one of those or both of those, and each time they were on it, they continued to use, and they're kind of fed up with themselves, and they feel that they'll have more self-efficacy if they have a shot at staying abstinent. So for that patient, oral naltrexone may be a very good treatment. There's also patients who are concluding agonist treatment. They've done a couple years of buprenorphine. They've been on methadone for 5 years. Now they have a job, they're married, they have a child. They want to be off of methadone. They don't want to have to go into the clinic every day. They don't want to have all of the requirements with take-homes, and they want to conclude it. And the team evaluates the patient and determines that this is actually a reasonable thing. But when they come off of the agonists, they can be vulnerable for some time. And they may want to be on oral naltrexone for weeks or months after they've been fully withdrawn from the maintenance agonist. So that could be a good patient for oral naltrexone. Let's say they have not had a severe course of opioid use disorder. They got into trouble after a pain episode, the doctor prescribed meds, they took too much, they got intolerant. It's been a few months of this, they realize they're in crisis, they want to get off the opioid, and they want a short-term medication that can be easily concluded without withdrawal or a long taper. Naltrexone oral might be a good medicine for them. And if the patient has a history of alcohol use disorder as well as opioid use disorder, or is currently actively using alcohol with an alcohol use disorder, naltrexone is effective for both if the patient takes the medicine. So these are people for whom oral naltrexone could be effective. Also, if somebody's getting ready to leave jail or leave rehab or leave a hospital where they've been inpatient or incarcerated long enough that they're fully off of opioids, they're fully withdrawn and have no lingering withdrawal, they could conceivably be a good patient for naltrexone, especially if they're monitored. If they're monitored to take it on a daily basis, and also if they're not allowed to be on agonist treatment. There are biased, discriminative practices throughout the country, particularly in the legal system, but also among employers, that do not allow patients with opioid use disorder to be on methadone or buprenorphine. They're wrong, but if they have the power to enforce that restriction, oral naltrexone may be a solution. So there are judges, there are even professional boards of health professionals that don't allow their monitored individuals to be treated with buprenorphine or methadone. Some employers will not permit it. If somebody is a trucker, drives a long-distance rig, subject to Department of Transportation random urine tests, if they show up with buprenorphine in their urine, they may lose their job. So oral naltrexone might be a solution. If they're in a school or sports team that does urine testing, buprenorphine and methadone will show up and may not be distinguished if they're not using the right test. And so those individuals may be suitable for oral naltrexone. But the key thing is that they need to have structure in their life. They have to have social supports in place. And the ASAM criteria considers 3 dimensions important here. Dimension 4 is readiness. They have to have good readiness. Dimension 5 is impulsivity or urge for continued use. That has to be low. And the environment has to be supportive of recovery and protective of recovery. So patients can have actually a severe history, and they may be burnt out and fed up with how they did on buprenorphine or methadone, And so despite that chronicity and severity, they might actually be suitable for oral naltrexone. Another group that's an interesting candidate for oral naltrexone is you got an 18-year-old, 20-year-old, maybe they're in college, and they have gotten into trouble with opioids. They haven't had a long period, it hasn't been a year or longer, so it's a shorter duration of addiction. They might be a good candidate. Now, if the patient is monitored and not allowed to be on agonist treatment by judges or professional boards or employers, they might do well, particularly if they can be monitored for daily naltrexone oral medication. A really great example of this is health professionals in recovery. So, it turns out that doctors and pharmacists and nurses become addicted at the same rates as the general population. Their training, their intellect, their income, it doesn't protect them from a disease that, as we understand nowadays, affects everybody. So they get sick with addiction, and actually they're not easy to treat. They can be very hard to treat, especially doctors. They can be smart, they can have great access to the drugs, and they're very shrewd at figuring out how to hide their addiction. So they can be very tough to treat. And yet we have great outcomes with doctors. 70 to 90%, depending on which study you look at, are abstinent and functioning 5 years later. So 5-year survival rates in cancer of 70 to 90%, that would be considered an amazing treatment. So we have that in our field. It's just that everybody else doesn't get all the benefits of effective treatment. So NTX-PO, naltrexone oral, can be an effective treatment, but only if the patient is compelled to undergo daily oral or 3 times a week oral naltrexone under direct visual observation and by a non-relative or non-significant other. So a colleague at the hospital, let's say, or in the practice. So that's what we do with physicians in early recovery. And we get terrific success rates with oral naltrexone and all the other counseling treatments that we provide to them. And that can be achieved by anybody if we provided them all these services and they had all the wraparound supports. It's also effective for short-term induction onto extended-release naltrexone. When we're starting to get people off of opioids and ready for starting extended-release naltrexone injections, we can use low-dose naltrexone, and I'll cover that in my next webinar, which will be in April, and that will be on extended-release naltrexone. So I won't spend time on that here. Now, there's another line of research that has gone on looking for a way to select the right patient for oral naltrexone, and it was a genetic research direction. There were a series of studies that thought that there might be a particular gene for the mu-opioid receptor, the opioid receptor for opiates, methadone, morphine, those are the M's, so it's a nice mnemonic. Mu-opioid is for the M's, the methadone and morphine type of opioids. And the hypothesis was, if you have a variant of this asparagine 40 aspartate gene, that you would respond to naltrexone more effectively than if you have just the asparagine. So there were a series of studies, and they were looking positive, and finally the group that was leading this research took this to the FDA and did the big multi-site FDA trial to test out if they could prove in a multi-site study that this works. And then we could use that gene, because we can test for that gene in people, and we could select patients for oral naltrexone using that gene. And this is it's called a genetic polymorphism. So they did a big study, 221 patients, multi-site, 12-week, double-blind, randomized controlled trial. Unfortunately, the results were that there was no evidence that there was a genetic effect on any of the drinking outcomes. and it didn't support the hypothesis. And here's what the data look like. So 100% of patients come in with a history of heavy drinking. And they get into treatment, they're started on the naltrexone or placebo. They're grouped into two different groups, the ones with the gene and the ones without the gene. And then they look at how much heavy drinking do they have over the next 12 weeks. And lo and behold, these lines aren't any different from one another. There's essentially no difference between the group that got placebo, the group that got that had the gene, the group that got naltrexone, the group that didn't have the gene. They're all almost exactly the same. And so we failed to find a gene for predicting this. But there are other things that can help us select patients besides genes. So I've covered a bunch of those, and now we can also talk about care planning that is effective for the patient who is selecting oral naltrexone. So if we're going to do oral naltrexone with the patient, we want to reinforce with the patient that they have to stick with regular, frequent appointments. Why? So that we can assess if they're taking the medicine, if the medicine is working, if their craving is down, if they're able to focus on learning new coping skills, facing stressful situations successfully without relapsing. We need to evaluate over and over again, is this realistic? Is the patient sticking with the medicine? Do we have evidence that the patient is progressing in their life? Now, clinically, how do I know if a patient is progressing in their life? It's not if a patient comes in and blesses me, says I'm one of the saints, says, oh, doctor, you've done the best thing I've ever had, and you're the best doctor in the world. To me, that's a patient that may not be progressing. Instead, if the patient comes in and in early recovery starts facing their emotions and says, yeah, it's really hard, you know, I'm suffering, I'm going to my meetings, I'm going to counseling, but you know, I talk about what's happened to me and I realize I've really destroyed my life. You know, I'm starting to talk to people at these AA meetings. It's so hard, I don't even know how to be friendly. I'm going back to work. You know, I feel like they're watching me. I'm doing better at work. You know, I think they might promote me. I'm actually scared about that because I've never had stuff go well for me at work. I don't know how I'll handle it. That's a patient who's actually progressing in their recovery. So the medication is just a foundation. If we don't see the house getting built on that foundation, we have to evaluate, is this realistic? Is the medication actually being taken, and is it working? In order to succeed with naltrexone, we have to have the appropriate level of care in place or be working to get the appropriate level of care in place. Now, ASAM says that naltrexone oral is compatible with all ASAM levels of care. Now, of course, not with methadone or opioid treatment services with buprenorphine, but for everything else, level 1, 2, 3, even hospital care can be started to stabilize a patient who's got psychiatric or medical illnesses, and you can actually start naltrexone if the patient doesn't have pain to start stabilizing them to get them ready for when they leave the hospital. So it's compatible with all ASAM levels of care. And if the patient has mental health concerns like depression, we want to get the mental health records, get psychiatric consultation, and consider what other supports this patient might need, since the naltrexone will lock them out of their old coping strategy. So if the patient has PTSD, and they used to use to get numb, how are they going to cope with their stress if we put them on naltrexone? They can learn to do that. That's what the counseling is all about. But we have to make sure we understand that need. We want to do labs. If the patient has liver enzyme elevations that we know of, if they have liver disease or a likelihood of liver disease, hepatitis C, they need periodic liver function tests. And if they are elevated more than 5 times normal, actually this is backwards, this should be reversed. It should be more than 5 times normal, then the patient needs liver enzymes checked periodically. If the patient is female, of childbearing age, sexually active, and not using contraceptives. The HCG should be tested, and if positive, the obstetrician should be consulted to decide what approach the patient needs, because we don't have research data on the effects of naltrexone on the fetus. Drug testing is essential because we need to know if the patient is negative for opioids. If the patient's being discharged from the hospital or detox or rehab, we want to see that discharge paperwork, including what medications the patient has been on, not just upon discharge, but prior to discharge, so we can figure out if the patient's been off opioids long enough to avert any precipitated withdrawal. So we have to confirm that no opioids were given. And we may want to do a naloxone challenge. Now, what is a naloxone challenge? Well, after you do a drug screen and the patient's negative for all opioids, and the patient confirms to you and the record confirms that they've been off the short-acting opioids, you know, Percocet, OxyContin, heroin, for at least 3 to 7 days or longer, and they're off of any long-acting opioids like methadone or buprenorphine for at least 7 to 10 days. With methadone, if it's chronic maintenance treatment, they should be off maybe 2 weeks. Then we want to check their blood pressure and heart rate and make sure that those are not elevated, because that could indicate that they're in a little withdrawal. And we want to do a formal assessment. The COWS, Clinical Opiate Withdrawal Score, or the CINA, the Clinical Institute Narcotic Assessment. These are good scales. The ASAM book actually uses the CINA score. COWS is also good, a little shorter. And you can find them on the web. You just type in Clinical Opiate Withdrawal Score, and you'll see it right there, and you can download it and use it for your clinic. If there are any positive opioid withdrawal signs, even if the drug screen is negative, don't do the naloxone challenge, because it's going to be positive. The patient will have some withdrawal, and that's uncomfortable. But if all of these are negative, then before we start oral naltrexone, we might want to do a naloxone challenge. So what is that? Naloxone is a liquid medication. It comes in these little ampules, and it's a very short-acting antagonist. It's a blocker like naltrexone, but instead of 24 hours, it really lasts about 15 minutes. So you use it to test if the patient is still in withdrawal, because if they're in mild withdrawal and you can't really detect it, or if they still have some opioids in their system but they didn't quite show up in their urines, then you give the naloxone challenge. It's very quick. Within 15 minutes, you see if they're having some withdrawal. It won't be that severe, and it'll be very brief. Within a half an hour, any withdrawal will be gone, and then you can decide whether to start naltrexone or not. So you want to give naloxone hydrochloride, 0.8 milligrams to 1.2 milligrams. It's an IM injection. It doesn't have to be IV. It's a little slower if it's IM, but it's still a very good test. And you might want to divide it into half doses, separated by a few minutes. That reduces the risk of seeing a severe withdrawal. And then once the 2 doses are injected, you wait 15 minutes and you repeat the COWS or the CINA measurement. And then you do it again 15 minutes later. If you haven't gotten any withdrawal signs or symptoms showing up, you give another dose of 0.4 to 0.8 milligrams of the naloxone, and you wait 15 minutes and 15 minutes again, and if the COWS or CINA scores are negative, then you have a successful naloxone challenge. The challenge is negative. They don't have withdrawal or opioids on board, and it's safe to commence the oral naltrexone. So a negative naloxone challenge is no subjective or objective withdrawal, and you can start with the 50 milligrams a day. A positive naloxone challenge is any withdrawal. There could be elevated blood pressure in response to the naloxone, elevated heart rate, sweating, tremor, even if it's fine tremor, if you just touch their fingertips and you notice now you're starting to feel a little tremor in there, that's a sign that the naloxone has produced a blockade that indicates withdrawal. And you don't want to go to naltrexone yet. So as soon as you see withdrawal signs or symptoms, and I don't mean a high score, I mean any of these symptoms, then you don't continue with the naloxone test. And you will see the withdrawal emerge within 5 to 10 minutes. That's why we tested 15 minutes and then another 15 minutes. But within 30 minutes of the naloxone, it'll go away. And the symptoms are usually mild, and you'll see things like the patient will complain they're getting jittery or their stomach is turning. Even that is a sign that they should not be given more naloxone or start naltrexone. And what happens if it's positive and you decide, no, we can't go ahead with the naloxone test or with the start of naltrexone? Well, just repeat the naloxone challenge tomorrow or the next day, because there may have been time for the opioids to clear the patient's system. So if we're going to use naltrexone, whether it's oral or extended release, there are some vulnerabilities the patient needs to be aware of, and that means we have to educate the patient. The biggest one is that since they've been detoxed and they're maintained on a blocker, they have lost their opioid tolerance. The blocker doesn't cause more loss of tolerance. It just persists. It just sustains the loss of tolerance. So the patient is vulnerable when they stop using oral naltrexone, which they often do. The patient is vulnerable if they go back and use the number of bags of heroin they used before, or the number of pills and milligrams of OxyContins they used before. They've lost their tolerance to that. Before, that would get them high or stave off their withdrawal, but now it'll get them way past high, and they could stop breathing, so they could die. So if they miss a dose and use, they have to know they cannot go back to using what they used to. That message does not invite people to go back and use safely and get high. And also, not telling them that and having them risk dying does not diminish their addiction or their likelihood to use. It's just information for a human being who we want to treat with dignity and advise that their life could be at risk. So we do want to tell them this, and we want to tell it to them often. We want to tell them when they're starting the treatment. We want to tell them in the middle of the treatment periodically. A good time to review this is if you're treating a patient who's an outpatient, and every month or later every 3 months you're doing sort of periodic review of their progress, then you want to remind them that they still have this vulnerability for relapsing with an overdose. If they want to try and break through the blockade on a day that they took their oral naltrexone, if they think, well, I'm being blockaded, I got to use, 10 times the number of pills I used before because I really want to get high, well, they could succeed in overcoming it. The blockade is competitive, it's not absolute, and therefore they could overshoot it and drop their respirations and die. So they need to know that they should not try to break through the blockade. Another management issue is that patients will no-show. And if they no-show, we have to chase them. If I no-show to my dentist's, tooth cleaning appointment, they chase me. Well, that's just to clean my teeth. If the dental hygienist is willing to do that, we addiction treatment providers should absolutely be willing to do that when the patient's life is at risk. If the patient has hepatitis, there are patients who have been safely treated. If they have chronic hepatitis instead of acute hepatitis, they can be treated with naltrexone, including both oral and extended release. But they should be made aware of the risk. You do want to talk to them about it. Depression and suicide patients need to know it's not a frequent event, but it can be an elevated risk compared to the general population and compared to placebo. And so patients should be monitored for their mood and for depression and for any risk of suicide. And their families and other caregivers should be notified as well that, we want to keep an eye out. Early recovery is very challenging. It's a very sad time, and people can get into a depressed state, a suicidal state even. On the long-term basis, once the patient is stabilized and is doing okay with naltrexone oral, they should still be coming to the clinic for visits every 2 weeks, and eventually it could be stretched out to every 4 weeks if it's a maintenance program. But we generally don't want to go longer than that. One of the reasons is people who feel they're doing well can get into what we call in AA a pink cloud. They can think, oh, I'm doing great, I really mastered this, I'm so happy I got treatment, I don't have to worry anymore because I'm going to be okay. Well, you want to see a patient every month at least to see if they're thinking that way and to caution them that the vulnerability will be there their entire life. So clinic visits every month with a monthly prescription refill. And if we're going to change the frequency from weekly to every other week to monthly, we want to do a team review to see how everybody perceives the patient's progress. And at visits, we want to perform drug testing and assess the patient's status, not just in terms of their craving and drug use, but across all 6 ASAM dimensions. Yes, any drug use or withdrawal. Yes, there are medical problems. Also, Dimension 3, their psych. Dimension 4, their readiness. Dimension 5, their continued relapse potential risk. And Dimension 6, their environment. All of these things are changing all the time with our patients in early recovery and even later recovery. We have to monitor for their adherence and their ambivalence. You want to ask the patient, what do you like about being on the oral naltrexone at this point? Anything you don't like so much about it? What do you like about being in recovery now? Anything that's hard, or you have any misgivings about the challenge of being in recovery now? And patients will share that if you're really open to it, and they'll teach us a lot about their risks. If the patient has a history of alcohol problems and you're using the oral naltrexone for not just the opioids but also for the alcohol, do periodic breathalyzers or ethylene glycol, ETG. The advantage of ETG is it detects alcohol use longer than the breathalyzer. After 12 to 24 hours, you're not going to pick up alcohol on the patient's breath, but you could pick up ETG for up to 3 days. And some of the urine cups now have that, and the saliva cups too. Liver function tests, if they were elevated, keep checking every 1 to at least 3 months, and make sure that medical follow-up is happening, because patients may not be that compliant with their medical follow-up, even if they're coming into the addiction program. Now, healthcare costs sometimes are a consideration, and our programs are not funded well, and insurance isn't great, and sometimes the stigma of society towards our patients allows society to shortchange our patients compared to medical patients and not pay for their care. And sometimes we ourselves get trapped in that kind of thinking. We, providers of addiction treatment, get stigmatized by society, and we sometimes inadvertently think that, well, I can't use expensive medicines for my patient, and I better go with, whatever's cheapest or it's easy to get for the patient. That's bad thinking. In fact, other medical specialties and healthcare providers don't think that way. They think if there's a technology or a treatment that's right for the patient, that's what the patient should get, no matter what the cost. If it's $35,000 a shot for a genetically engineered new medication for a patient's critical disease, most healthcare professionals think that's fine. We need to start thinking that way too. But it turns out for oral naltrexone, it's not a big problem because the costs are low. Here's the cost of the medicine plus 6 months of treatment for both the substance and the medical conditions, including ER visits and hospitalizations. So it's really the same for oral naltrexone and in the same range as extended-release naltrexone and in the same range as buprenorphine-treated patients. So there isn't a cost difference when it comes to oral naltrexone, and we shouldn't be worried. It is a generic. It is fairly cheap for the patient to take, but that should not be a basis for its use. So here's what I said I wanted you to come away with as a result of the workshop. I wanted you to understand the brain receptors and the clinical effects of oral naltrexone, because it does have clear clinical effects at known brain receptors. I wanted you to be able to describe the limitations in clinical care. So I wanted you to appreciate that it's the problem of persistence, of sticking with it each day, when you have a daily oral medicine that you don't love because it doesn't make you feel better. And I wanted you to understand the appropriate roles of oral naltrexone. Who would it be right for? Who might have a harder time ever succeeding with it? And I hope we've achieved these objectives. So the conclusions are opioid use disorder is a chronic disease. It needs both longitudinal rehab with meds and with counseling. We need a stable foundation to construct the house of recovery, and then we have to construct the house of recovery. The medicine alone is not a recovery. The goals of treatment and retention and rehabilitation, saving lives, stabilizing behavior, establishing social function and citizenship. That's ASAM's definition. The agonists and the antagonists are both good FDA-approved approaches. They're both superior to counseling alone without any medication. All FDA-approved agents are appropriate first-line agents, and oral naltrexone is FDA-approved. So we should be offering all of these options, including oral naltrexone, but we shouldn't be offering them on the basis of cost. Low initial costs can end up being high costs later. High initial costs can end up overall in the long run being low costs, and therefore we shouldn't be worried about cost. We should fight the pressure of insurers to guide our treatments based on cost. Ultimately, patient choice and patient circumstances and needs and preferences, using the ASAM criteria and using discussion with the patient and loved ones if they're available, that's probably the best choice, the best basis for drug selection. And finally, if one treatment doesn't work, we should use another medication treatment. It doesn't mean we stop medication treatment. It just means we switch, because we have very good alternatives. These are quite different, all of them, all four. And that's at least a decent starting place for medication in addiction treatment. So naltrexone is a potent blocker. It was a natural consideration for MAT in opioid use disorder. But for most patients, studies haven't found it to be better than placebo or non-medication treatment because the patients have so much trouble adhering to it. The genetic studies didn't work out. We don't have a biomarker. The FDA has not approved anything on that basis. But it's still used. There are maybe 10% to 15% of patients for whom pill taking can be monitored. It can be used for detox and induction onto extended-release naltrexone for patients who completed MAT, but they have new stressors and they want temporary protection without physical dependence. And all of these are legitimate uses for this medication. So I'm going to stop there and look at your chat and your questions. Please type them in at the upper right side, at least on my screen. There's a Q&A box. Click on that and you'll get a little window with a box down on the lower right that you can enter questions and just type your questions in and I'll see them. So we've got a bunch of questions and let me start answering them. Somebody expressed a lot of appreciation and felt that this needs to be seen by everyone in the profession, and especially the medical staff. And I appreciate that. Medical staffs are not well versed in the ins and outs of all these details, and fortunately, you should be working in teams. You should have communication with them. Bring up these ideas. These webinars will all be posted through FADA, thanks to DCF's support. And that means people can go online and watch these videos of the slides and the audio at any time. So thank you for your comment about that. Is it possible that medical docs don't know how to do this? Do you recommend only addiction psychiatrists do this, but there aren't that many of them? That's so true. You know, we produce about, I don't know, 50 to 100 addiction fellowship doctors a year in this country. That's obviously nowhere near what we need in the middle of an epidemic. Generally, primary care docs do not know how to do these treatments, but they can. ASAM has great courses for not just learning, but also getting certified for buprenorphine. The drug companies will send out reps to train the doctors and the nurses in these medicines, and that's free, and they'll come on your schedule. So that's perfectly legitimate. Yes, they're there to sell, but they also have a lot of information, and it's FDA-approved good information, so it's worth having them. Other questions on the chart that compares oral versus extended-release naltrexone. Is there a role for both? That is, when the extended-release naltrexones start to decline mid-month, can a low daily oral dose of naltrexone oral, starting at mid-month, help sustain the curve of the declining extended-release naltrexone? Or is this not a good idea? So that's a really good question, and I think you're asking this question because you're doing this. You're treating the patients, and you're observing their response. So that tells me that you're really doing a great job, and I want to go into this answer in some detail. So this is the blood levels of oral naltrexone and extended-release naltrexone, Vivitrol. You are seeing the extended-release naltrexone declining in blood levels over the course of 30 days. The truth is, however, that at 30 days, this is still sufficiently present in the bloodstream, and that means in the brain, at doses that are still effective for the blockade of the receptor. Now, we say it's a 30-day medicine, but actually, it's been measured out as long as 56 days. It doesn't just fall off a cliff here, and it's not getting so low that it's not effective. So why is it that some patients actually do say they're craving more, they're finding that they're using drugs more, and we see some patients dropping out in the 4th week, let's say, of the month? And some people have called this the 4th week effect with Vivitrol. And the 4th week effect is, they think, oh, maybe it's a sign that we have rapid metabolizers. They're eliminating their naltrexone quickly. Well, the problem is there is no such thing identified as rapid metabolizers. We don't know of an enzyme that's doing that. We don't know of patients who have that condition. So people have sort of invented the idea, the concept, as a possible explanation for this. So I was very concerned about this when I was working at Alkermes as vice president there, and I commissioned an analysis to try and figure this out. Here's what we did. We took all the data from the big FDA trial, 250 patients, half on placebo. They got an injection with the microspheres, but no naltrexone. They got the same counseling as the people on the Vivitrol. And we took their 6 months of treatment, but we divided it up into week 1, 2, 3, and 4. So within month 1, we looked at week 4 versus week 1. Within month 6, we looked at week 4 versus week 1. And we stacked all the week 4s on each other, and we stacked all the week 1s on each other. And we looked at how patients were doing. Now, it turns out that it's true. In week 4, compared to week 1, more patients were having craving. More patients were using drugs. More patients were starting to drop out in week 4 compared to week 1. Every month, we were seeing this kind of pattern. But, and here's the critical thing, the people on placebo were having more craving in week 4 too. The people on placebo were using more drugs in week 4 also. The people on placebo were tending to drop out more in week 4 than in week 1 also. And at the same rates of those increases as the people on Vivitrol. What does that tell you? That is a definitive, double-blind, randomized control comparison of this problem. And what it tells us is the week 4 effect is not pharmacologic. It's not a decreasing amount in the bloodstream of naltrexone. It's psychological. It's expectancy. It's thinking, oh, I have to make a decision in week 5 as to whether I take this injection or not. Oh, I'm getting teased. Maybe I want to use again. Maybe I want to relapse. Maybe I want to be free of seeing doctors. So that psychological impact has to be addressed. But just giving a low oral daily dose of naltrexone at mid-month, that's not going to do it. Because that's a pharmacologic approach to a problem that isn't pharmacologic. So we don't want to give the injection sooner. We don't want to use oral naltrexone for that. We want to counsel. We want to help the patient anticipate. Hey, guess what? You're going to feel really good midway into week 1 and 2. But by week 4, you're going to be wondering, what do I do? What do I do? And that's going to stress you. And guess what? The coping with stress is something we deal with in counseling, which is why you don't just need the medicine, you also need the counseling. So I hope I've answered that question. We're getting to the end of our time, and I want to thank you. We had over 50 people on this call, and for a medicine that we generally have, given up on, to have that amount of interest across the state of Florida is really great, because we need all of these tools. We have quite a range of people suffering from opioid use disorder, and in the midst of this epidemic, to have all these tools available is really helpful. So I want to thank you. I want to thank FADA for sponsoring this. I want to thank DCF for funding this in the midst of the epidemic, and thank all of you for the work that you do every day, and good luck.
Dr. Gastfriend, thank you so much for that. I'm going to go ahead and take control back of the presentation. And Dr. Gastfriend, just so you know, there was a final comment that came in through the chat panel while you were addressing the last question. I'm going to go ahead and proceed through our concluding wrap-up remarks, and then I'll loop back to you if you wanted to say any final thing about that one last comment. So in conclusion, of course, we thank Dr. Gastfriend very much for sharing his expertise with us today on this topic. And I do want to remind everyone on the webinar, especially if you joined us a minute or two late, that when I do conclude today's webinar, your browser is going to take you to an evaluation on FADA's new website. If you would like to receive continuing education credits or a statement of credit for the event, please do complete the evaluation for us. You will be prompted to register if you haven't already done so, or to log in to complete the evaluation. And you can certainly register as a visitor, and there's no charge to do that. For continuing education units to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number at least the first time that you register with us. After you register, you will be directed onward to the evaluation. Do note that the evaluation closes at midnight on Thursday, March 22, and that's just at midnight tomorrow. But you're also going to get a second opportunity to complete the evaluation through a follow-up email in about 30 minutes, and it will come from FADA On Demand, so just watch for that. And then lastly, after we conduct our verification of your attendance and the evaluation, we will post your statement of credit and send you an email to let you know that it's been done for you. This email will come from info@fada.org. And so before I wrap up, Dr. Gastfriend, did you want to say anything else?
No, I just want to thank everyone for your attention and for your comments, too. I really appreciate it.
Okay, wonderful. So thank you to all of our participants for joining us for the webinar today, and would also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. So have a great rest of your day, and please do hold for the evaluation. Thank you.